From Diamond Pharmacy Services, this is PodcastRx. On this episode, pharmacist Henry So from the optics team returns for a straightforward clinical discussion of bariatric surgery. We talk about the history of bariatric procedures, their efficacy, and the risks and downstream effects of surgery. We also cover what role pharmacists have in post-bariatric patient care and what Henry and his team have done to assist providers in this area. I'm Adam Campbell, and thanks for listening to PodcastRx. I'd like to welcome pharmacist Henry So from the optics team back to PodcastRx. Henry, I think this is your third or maybe it's your fourth time on the show. Anyway, it's always a pleasure to have you back on, and thanks for taking the time to be here.
Thanks, always a pleasure.
A few episodes ago, Henry, I was talking with your colleague Chris Bender about the GLP-1 agonists. We focused our discussion primarily on semaglutide. Semaglutide's really having a moment in pop culture right now, especially Ozempic and its off-label use for weight loss, especially among the celebrity and social media influencer set. And we do talk a little bit about that in that episode, so do encourage you to go back and listen. And one of the things that we talked about was that one of the big selling points of drugs like Ozempic and its officially approved for weight loss higher dose counterpart Wegovy is the potential to deliver weight loss results comparable to bariatric surgery. So now someone struggling with obesity can administer injections to control weight rather than go under the knife or go through with a surgical procedure. And these new medications, they haven't made bariatric surgery obsolete. They aren't miracle cures. As with any treatment, what works for one set of patients simply may not work for another. And while surgery has risks, just like the medications do, bariatric surgery remains very effective when performed on appropriate patients. And on top of that, GLP-1 agonists can also be used in the aftermath of bariatric surgery to aid in recovery. And so, Henry, that's what I wanted to talk with you about today. I wanted to get a better understanding of bariatric surgery overall, its effectiveness. I want to get a better understanding for how a clinical pharmacist like you is important to surgical patient care and recovery. So first thing I'd like to ask, Henry, how did this topic become of clinical interest to you? Many of the episodes that we do are based on presentations or webinars that you and your optics colleagues have developed. So how did you come to focus on bariatric surgery?
Yeah, so typically the issues that we run into as a clinical pharmacy team are mostly from day-to-day questions or even just reactively from something new that comes out or something landmark. This particular topic I was interested in because I just had a few providers just come to me in a way where they were like, I have a patient who is, a couple years post-op from bariatric surgery. They're telling me that they need certain vitamins, minerals, et cetera, to be able to live a healthy and normal life. And essentially, they come to us with fairly expensive combination tablets tailored for bariatric surgery patients. And what we've done a few amount of times, enough to the point where we have written something about it in an article for a clinical update, is where we just list out and help them mix and match the different vitamins and minerals that they need to take. So that's one of the things that really kind of drove us to be able to just put something out there and say, here it is before you ask us again.
Yeah. I want to get into all that a little bit later in the podcast, but before that, Henry, could you give me a brief overview of just what bariatric surgery or weight loss surgery is, and just a general brief history of it, the types that are available today, who gets it, the efficacy, risks, so on and so forth?
Yeah, I mean, the best way to put it is, before I really get into some of the more, how it started, how we've progressed, it's essentially two schools of thought exist for bariatric surgery where there is a restrictive procedure and a malabsorptive procedure. One came before the other, as in the restrictive rather. But what it is there is a surgical procedure that shapes the stomach in a certain way, a certain sleeve, or even there are rings that are created or punched through the stomach, and as well as elastic bands that are put around the one component of the ring that's punched through, to create the feeling of kind of restricting the stomach's ability to stretch, contain food. Typically, your stomach should be able to contain about 4 to 6 cups of food or any type of volume. Once they started restricting these patients' stomach sizes, they were restricted to about 1 cup. So just the physical limitation itself, that should be able to help patients in that sense when it's restrictive. The stretch receptors involved when you eat, a smaller portion of food that you're normally versus what you're normally eating. Those stretch receptors involved with satiety as well really come into play. Malabsorptive is when they started to take a part of, they would split the stomach really. They would take the lower half and they would continue it forward, or they would take the upper half that they made a restrictive pocket of the stomach. They would go in and connect it to a lower part of the small intestine to create the malabsorptive feature that we're typically know about. So I do want to share with you, Adam, though, because I shared it with the
Mhm.
team. It was really fun. We love to bounce back and forth ideas as well as some fun little things. Just like for example, I know that just a pop quiz or anyone that follows our podcast, you can go back to see what Chris Bender talks about how we derive some of our GLP-1s and some of the crazy animals that we've dealt with in that realm. But
Yeah.
I'll try to keep it brief. The history is fairly robust, I would say.
Mhm.
I've got quite the timeline that I could communicate. You can stop me anytime; it gets boring. But
All right.
first bariatric surgery, through historical reports and claims, was done in the 10th century by D. Sancho, which was the king of Leon, and he was reported to be a rather obese individual. He could not walk, ride, or even pick up his sword. So if you ever watch movies like Braveheart or anything like that, it's like, you can't really have a king that isn't out there on the battlefield, right? So
Mhm, mhm.
he subsequently lost his throne. And right after that happened, his grandmother, Cordoba, took him to a famous Jewish doctor by the name of Haste ibn Shafrut. And what he did is he sutured the king's lips closed. Um, I, I think that's very gruesome, but I guess they got the job done in that sense. They were only able to feed him through a straw with a liquid diet, and it consisted of like something called teriyaka, which is a mix of herbs as well as opium. So that's interesting as well.
Yeah.
It's a happy ending. We all want a happy ending. Sancho lost half of his weight, returned to Leon on his horse, and regained his throne. So yeah,
Wow.
there's that. I can keep going if you want, if you think it's interesting enough.
Yeah, that's good. What are some other examples from antiquity?
Well, it gets a little bit more boring from that point forward. There was a bunch of physicians that dabbled in metabolic surgeries in the later half of the 1900s. You had Dr. Kremen that did the first jejunal ileal bypass. Their first intention for that was to actually treat high cholesterol by bypassing much of the small intestine to prevent absorption of nutrients, lipids, etc. Quickly dismissed, however, there was severe diarrhea, dehydration, a lot of metabolic consequences from that. Later on, there was a Dr. Mason of the University of Iowa in 1966. He just kept noticing how patients that with certain gastric cancers, after their total gastrectomy, just lost a decent amount of weight. So he then proposed a bariatric surgery, like a similar surgery to that, except it's not a total gastrectomy. And he dissected and trimmed away parts of the stomach, so that a very minimal amount of food was able to fit. This is kind of like where our restrictive procedure comes in terms of its first historical presence. This is what created that smaller stomach size, um, more prone to stretching because of its smaller size, and patients feeling physically limited or really full just from eating usually a sixth of what they were supposed to eat. Um, yeah, but overall gastric bypass, that component of itself, the restrictive procedure, um, definitely did not gain a lot of traction. There was not a lot of success because patients continued to eat. And also, what they had were issues of bile reflux and gallstones. Basically, if you could imagine in your mind, the first gastric bypass surgery or restrictive only component was they cut the stomach in half. You had the smaller pocket up at the top that connected down, whereas the bottom half of the stomach just kind of funneled through and created gastric acid and bile, independent of food actually even reaching that component. But basically, what they did was to be able to eliminate that risk of like gallstones, bile reflux, and other metabolic issues. Was they took that bottom portion of that stomach and attached it with like an anastomosis or suture where they developed like a Y shape, and they basically connected at the same channel down at the lower part of the small intestine. And that Y shape is basically the name that they gave it, the Roux-en-Y gastric bypass. So that is what resulted in less diarrhea, kidney stones, gallstones. But yeah, that's pretty much the history of it.
Given all the developments you just talked about, then what are the main surgical options today?
So I would say a majority of patients will get the Roux-en-Y gastric bypass, and they'll also get like other procedures that might be a little less invasive, such as gastric banding, where they put like a like a elastic band around a certain part of the stomach. Um, when risks and benefits are finally discussed, I believe there are unattractive factors with certain things like the Roux-en-Y versus just doing a completely strictly restrictive procedure alone, whether it's done surgically or with like an elastic band. So those are the two I typically see or hear of: Roux-en-Y or some sort of restrictive procedure only.
And then there's also sleeve gastrectomy, right?
Yeah, that sleeve gastrectomy is similar to the restrictive procedures where they're just kind of, think of it like they're sewing, like they're stitching a part of the stomach where it clamps down on the part that they stitch on, and it forms like a narrow rectangular sleeve where that's where the food will reside, even in the upper half of the stomach.
Who are the typical patients that receive bariatric surgery?
So the typical patient would be anyone that really has failed conventional diet, exercise. A big thing really is our growing understanding of incretins related to satiety, or just the satisfaction associated with eating. Essentially, your brain knowing when to understand that it is full and time to stop eating. So typically, you have a lot of agents, anti-diabetic agents that can promote some sort of weight loss, a few kilograms here and there. You could even have patients on like what we've mentioned, GLP-1s like Ozempic, Wegovy. But the thing is, there are some patients that continue to fail these therapies, and we'll get into that. But the real patient that really should receive it, it does kind of blend into each other. But those that are morbidly obese, those with type 2 diabetes, it has been indicated for hypertension as well as obstructive sleep apnea too.
And how well does bariatric surgery work?
That's yeah, it's a really good question because the numbers are fairly staggering. So within the first 6 months, you can probably see about 30 to 50% excess body weight loss. As early as 12 months, you could see up to 77% of that excess weight loss. Um, Overall mortality rates, um, it is not as attractive though. It's about 40%. That time frame, however, from what I've reviewed, is starting from as soon as after, even years down the road, because there's things that can be complicated from creating a few. So I mentioned anastomosis earlier, and then an anastomosis is where someone essentially creates a new channel or new like a pipeline. Like you have a pipe. Think of it as a pipe where you just detach it from one section and attach it to another. I mean, these guys are going as far as creating a Y shape in your gut. So the potential for infection is, very real. They can leak your peritoneum or, within your stomach area that houses all your organs. That's supposed to be sterile. anything that's not sterile that's leaked in can cause some pretty bad, intra-abdominal infections. Other things like you can see patients that have such a vast recovery or change in their blood glucose while on continuing to be on blood glucose agents. And this is one of those things that a pharmacist can definitely chime in on, a physician saying, I have this guy on sulfonylurea and they continue to be hypoglycemic. And then, we find out, hey, they had gastric bypass surgery like a month ago, or, maybe it wasn't discontinued afterwards or something like that. But overall, the success rate in terms of the numbers and not the failure rate, rather, they're kind of up there. They definitely are very, very effective, but the acute and chronic downstream consequences of gastric bypass surgery, it's up to 40. It's not up to 40%. The mortality is, rather. I'm sorry. Yeah, mortality.
I want to ask you a little more about those downstream effects, but what about the efficacy of procedures between the different kinds, between the Roux-en-Y gastric bypass or the sleeve? Is there significant differences in how effective those are between each other, rather, when compared to each other? Yeah,
I would say the mortality rates would be different more. Um, I did not look into this too much, but I do know that the general consensus is there's two schools of thought. Whether you got the restrictive alone or the restrictive plus malabsorptive, that would be the biggest difference in terms of what's more efficacious than the other. So there's different names for it, like the Roux-en-Y or the biliopancreatic diversion, things like that. Um, but the best efficacy will come with the combination of restrictive plus malabsorptive.
Thanks for listening to PodcastRx from Diamond Pharmacy Services. If you're a fan of the show and have any topics you'd like to hear us discuss, or if you have any thoughts on a particular episode you'd like to share, please email us at podcastrx@diamondpharmacy.com. And while you're at it, please rate and review our show wherever you get your podcasts. Your feedback helps us make the best show possible for you. And as always, we appreciate your feedback and support. Now back to the show.
what does their journey look like in terms of the medications they then have to take, the lifestyle changes and the like?
Yeah, so I I do have a few points on this. I mean, it's really quite the long journey. So just to address kind of, I guess, the latter portion of your question, what does their life look like? Pretty complicated in my opinion. I mean, you can definitely get into a groove and figure out a schedule that works for you, but there is a few different providers involved with the care, even to the point where an endocrinologist um, will have to have a hand in your care because of the fairly severe glucose abnormalities that can occur. Um, in terms of complications or downstream issues, et cetera, uh, it really does come down to, first and foremost for me, that would be the biggest issue is sugars. So earlier I mentioned something called dumping syndrome, and then there's also post-gastric bypass hypoglycemia. They are actually very significant contributors of mortality in gastric bypass surgery. So early dumping syndrome, it's a condition that occurs within 1 hour of eating. The symptoms can consist of nausea, abdominal fullness, diarrhea, fainting, sleeping, weakness, and notably a desire to lie down as well. Uh, Pretty similar with the PGBH, what I just spelled out or said, post-gastric bypass hypoglycemia. But this condition can happen as early as 6 weeks and can affect up to 20 to 40% of these populations. So honestly, the thing about this is I'm not entirely aware of how long. I know I've watched the TV shows where the the physician in the 600-pound something story or documentary, they encourage people to go home fairly quickly once they're able to tolerate like a house diet or a normal diet. But yeah, this can happen as early as 6 weeks. And if at any point within those 6 weeks you are already home or within a different setting, it would actually be, other than the symptoms being fully well understood and the primary physician understanding or the family being educated to recognize it, the only real way to recognize this complication is through imagery. There are things like adhesions, like little, I guess, little pockets of tissue that might contain bacteria, or even fistulas being something that the body kind of creates as a new pathway to move a certain fluid or something like that. And that's kind of out of the scope of what's readily available for most people in a home setting. So it's really important to understand that at any time, if these symptoms that kind of mesh with the symptoms of just getting your entire um, peritoneal cavity like rearranged, um, if you experience this can be a very life-threatening um, complication. The other one I talked on many, many times, but it's very true. It's very real. When you're creating new channels and new pathways to even create like a Y shape in your gut with your small intestine and stomach, uh, infection is going to definitely be a huge issue in that sense. An anastomotic leak, any leakage of food material. So those are really kind of like those acute and present complications. There are others that I can discuss as more of like a short/long-term implications, as in, if you don't do this right for 10, 20, 30 months up to like 10 years, you're going to see some issues that are very real and very um, that have a relationship with how things were not addressed when you had bariatric surgery.
And real quick, what would those be?
Okay, so I mean, I don't know how quick I can be. They're pretty long.
Th-
They're
that's all right.
I'm just kidding. No, it's so think of it this way. You're having the malabsorptive component of a gastric bypass surgery, or typically your Roux-en-Y. And what you're doing is the stomach is minimized in its size, and the key areas of your organs or your gut organs that absorb things like calcium, vitamin D, iron, um, they're completely bypassed. So you're kind of just removing a lot of your small intestine from even having any action in terms of being able to use its high surface area to be able to absorb these nutrients. So there's that. So things you can think of is like calcium. Low calcium can lead to other metabolic disturbances, obviously, but the most physical and tangible thing we could see is osteoporosis, fractures, hip breaks. Vitamin D comes into play with that as well. Iron, you can have different types of anemia that arise. You could have patients that are constantly out of breath or just feeling always tired and weak. This surgery should be promoting the ability to live a healthy lifestyle and feel like you're energetic enough to be able to do these things. So that's another nutrient or um, mineral that you would not be able to absorb. Other thing is, so you can get nephrolithiasis or kidney stones. Uh, this actually is happening. This happens fairly often, and it's ranked by actually the biliopancreatic diversion is the highest, the Roux-en-Y is second, and then for all the rest, they're ranked equally in terms of the highest to lowest incidence of kidney stones. So, Adam, I've never had, not to overshare, but I've never had an issue with kidney stones. Um, that is something I never want to have to deal with, based upon some of the pictures I've seen of the very malicious looking stones that come out. So for these individuals, this, for lack of better words, this would really not be fun. So what the issue is there's low urinary volume, so they're maybe not drinking enough water, and there's a low urinary citrate concentration, as well as a high urinary oxalate So that's in the setting of malabsorption and improper consumption of calcium. So three different things can happen just from gastric bypass alone in order to prevent this. And it's something we could put in if like we ever have a physician that wants us to be consulted for a patient case for bariatric surgery. We would put in as one of our non-pharmacologic measures, drink up to 2.5 liters per day, barring that they're not any kind of, in an overloaded condition or fluid overload condition. So with a sipping fashion, telling them to avoid oxalate-rich foods and having appropriate amounts of calcium intake, especially as a citrate salt. So that's another thing. There's vitamin D malabsorption. This loops in with low calcium levels as well. But overall, there is a fairly high amount of vitamin D malabsorption going on as well. So that ties in with the bone outcomes as well. Binge-like behaviors can occur. So that implication in of itself can compromise the elasticity of the restriction of, or the actual intent to be restrictive of the stomach, as well as if there were certain sutures or staples used to be able to create a new shape of the stomach, that can burst. So that could be another issue that someone would, really wouldn't want. So typically these binge-like behaviors are already addressed by kind of like a psychiatric eval. I know that's one of the components of bariatric surgery, just to see, even if you were told and you physically cannot eat what you used to, is this person still going to eat in that fashion? And if that were to arise again or occur again, even if after they screen for it, there's things like phentermine, topiramate, et cetera, to be able to recommend in that sense. Also, just to loop it in there, like in terms of short-term implication, the glucose. And what that ties in with us as a pharmacist is there are things that we look for, as in, can you minimize incretin-based therapies? Can you reduce insulins? Should you? And typically overall, whether it's the thiazolidinedione, SGLT2, in order to prevent any adverse effect or event, those should be discontinued or considered to be minimized or monitored more closely. And lastly, you can get cholelithiasis or gallstones. Those can occur. They can be mitigated by off-label use of ursodeoxycholic acid, or simply put, just ursodiol. The biggest risk factors for that is female sex, premenopausal status, and those who have a Roux-en-Y average about a 30% occurrence, whereas all others will average a range of 7 to 53%. So not a very promising number or range.
Henry, then what have your experiences been in your current role in the optics team with post-bariatric surgery patient care? What kind of things are you tackling and what kind of questions are you answering?
Yeah, I think the biggest thing that I will say that we've tackled, and the most impactful, would be discussing and kind of doing the risk benefit of continuing certain anti-diabetic agents. A lot of them can be very expensive. A lot of them can be, such as your lower generation sulfonylureas, they can be a little bit more hypoglycemia inducing. So the biggest thing is just kind of shooting back and forth, like what's the risk benefit of continuing this? They are still a diabetic in name. So that is something that I would say is the biggest thing that we take care of. There are reassuring factors that we can discuss, as well as fairly quick and decisive changes in hemoglobin A1C, as well as fasting blood glucoses. So that in and of itself should be able to help justify that. But for the meat of it, and the most common, is just dealing with the different vitamins and minerals that are required to be taken, creating schedules, and finding out even what the best way to take it is, whether it's through a combination tablet, because there are only a certain amount of times per day that a patient can take certain supplements, versus, basically this a sample schedule that I've seen and communicated before had up to like 7-8 different times that a patient would have to show up and be administered something.
Are there any other areas, Henry, that pharmacists can help oversee and ultimately make post-bariatric surgery patients' lives better?
Yeah, that's a great question. So I've already pretty much said everything that we can do in terms of highlighting or pointing out some of the things that need to be done to prevent things like kidney stones, bone fractures, breaks, hypoglycemia, life-threatening hypoglycemia. The thing that pharmacists can do is not being typically in there, down in there in the trenches with some of these providers, nurses, and other groups, is we can use our position of education as well as empowering others with knowledge to be able to say, hey, I read that article from the clinical pharmacy team, or I listened to that podcast, and I know that there are certain things that are very critical for me to do for my patients with a history of gastric bypass surgery, or if already approved, just being ready to implement this type of intervention or complex amount of interventions to be able to sustain their health in a way where, great, they got the actual procedure done, but now let's get them to where they need to be and have them stay there. So education really is our biggest thing. And usually when I'm grappling with this question, I do stay on, I stay on with the provider and I try to walk them through it. But what I also try to do is I try to send them this material and have them be able to look through it, because I did create it in a format where, you get through the meat, you get through the why, you get through the how, but there are tables that are present, even sample tables, where it shows the different schedules that you can utilize to be able to have these patients get all of the nutrients in that are needed, as well as the signs and symptoms of certain critical conditions like hypoglycemia, dumping syndrome, and when to know, we need to escalate level of care. So yeah, only thing is really education at that point.
And education is, perhaps the pillar of what you all do in optics. All right. Well, Henry, so I want to thank you so much for taking the time again on PodcastRx to share your expertise with us. And I look forward to the next time you'll be on.
All right. Well, thanks so much for having me again, Adam.
This podcast features conversations with healthcare professionals. Their statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Catch our new episodes on Apple Podcasts, SoundCloud, Stitcher, Spotify, or wherever you listen to podcasts. Please rate the show and leave us a review. And if you have a topic you'd like to hear about on the show, or you'd like to share your thoughts on an episode, you can email us at podcastrx@diamondpharmacy.com.